So we'd like to thank our co-sponsor who accredits our program for CME, and that's the Duke CME organization. Next. I'd like to acknowledge our planning committee, which includes members of our board of directors and our activity medical director, Dr. Evelyn Lockhart. The Duke CME requires that we not only acknowledge the disclosures for each of the participants that you'll hear from today, but also the disclosures from our planning committee members. The mission of our organization is to make sure that healthcare providers are educated about the unique needs of women and girls with blood disorders. And our work won't be done until every woman and girl with blood disorder is optimally diagnosed and adequately managed at every life stage. Today's program, we will hear about women and girls' blood disorders throughout the life cycle. I'd also like to acknowledge our medical advisors, without whom we could not do our work. And I would also like to acknowledge our medical advisor, Dr. Nancy Andrews, who's the dean at Duke University, and who at this meeting will receive the Henry M. Stratton Medal for Basic Research. Our medical advisors are a multidisciplinary group. They include hematologists, obstetrician-gynecologists, internists, pediatric hematologists, as well as adult hematologists, emergency medicine physicians, genetic counselors, and I'm sure I'm leaving some group out. But through this multidisciplinary effort, we hope to educate all healthcare providers, as I said, about the unique needs of mothers and girls with blood disorders. After the program's over, I'd like you to remain interested in the topic, and I'd like you to direct your attention to our website. We have a couple unique features. One is we have a library where you can access articles relevant to this topic that may not be available except through journals with restricted access, but we have obtained permission to use the articles and have them available to use through our library. We also have an Ask the Expert feature. We also have up-to-date news articles about women and girls with blood disorders, and we want to keep you apprised of events and programs on the topic. This program will be archived and available early next year. We have webinars through women and girls with blood disorders that have also been archived and are available to you. So tune in. If you just type in Women and Girls with Blood Disorders, Foundation for Women and Girls with Blood Disorders, or fwgbd.org into Google, you should be able to pull up our website. Next, I'd like to introduce Dr. Barbara Konkle, a fellow member of the Board of Directors, who is the co-chair of our program this year and will moderate our program and introduce our speakers. I'd like to welcome you again to the program and thank you very much for coming.
Thanks, Andy. Again, thank you all for making your way down here. It's really my pleasure to moderate this program. I think you have a real treat because we have a broad topics that really touch on issues related to females with blood disorders from throughout the lifespan, and have experts in all of the areas, including some of our OBGYN colleagues who have come just to talk to us this morning. But I will start out first by introducing our first speaker, Dr. Kim Smith-Whitley. Kim is the Associate Professor of Pediatrics at the University of Pennsylvania and is the clinical director of the Division of Hematology, and more importantly, the director of the Comprehensive Sickle Cell Center there, which is really a model, outstanding sickle cell program. And she will speak to us this morning on adolescent sickle cell disease and reproductive lifespan issues.
Thank you to Drs. Konkle and James for the invitation to speak this morning and for that introduction. I am pleased to present the topic adolescent sickle cell disease and reproductive lifespan issues. I need to disclose that I have participated in advisory panels for Grifols and for Pfizer. And I would like to just point out that the two objectives for this talk this morning are to apply available options for optimally managing menses and menstrual pain in adolescents with sickle cell disease, and to describe and apply the full range of reproductive choices available to young women with sickle cell disease and sickle cell trait. So I'd like to start with an overview of what I'll be talking about this morning. Would initially start by presenting trends in morbidity and mortality and healthcare utilization in sickle cell disease that have really had some recent changes and some interesting publications over the last couple of years. I'll then go into what the challenges are in transitioning youth and young adults with sickle cell disease from pediatric to adult healthcare. And then emphasize the need for reproductive counseling in adolescents and young adults with sickle cell disease. And then briefly touch on pain and menses with women with sickle cell disease, but take a deeper dive into the options for contraception in women with sickle cell disease and sickle cell trait. Before we do that, we're going to start with two pre-test questions. So question one, you're going to take out your interactive devices, and we're going to see how awake you are this early in the morning. And given inconsistencies and recommendations regarding hormonal contraception use in women with sickle cell disease, may there be, one, or A, decreased prescribing of hormonal contraception, B, decreased usage of hormonal contraception, C, increase unwanted pregnancies in this patient population, or D, all of the above. All right, and then the next question. We'll hold the answers until later. We'll give you a chance to see what you do after my talk. The second question, the recommendations for contraception in young women with sickle cell disease and no neurologic or thrombotic complications include progesterone-only containing hormonal contraceptive medications, low-dose estrogen-containing hormonal contraceptive medications, barrier methods, all of the above, or E, A, and C. All right, now we'll go on. So can we go to the slide prior to that? So Charles Quinn recently published some interesting statistics demonstrating that compared to prior studies that demonstrated a median lifespan of 18 years in the 60s and 70s in individuals living with sickle cell disease in the U.S., that we really had an increase in survival, that now 93% of children born with sickle cell disease will live to 18 years of age. You can see in this lower panel here that in the Jamaican study, this was more consistent with what we saw in the U.S. in the 60s and the 70s. But then with each decade, we've really improved the survival of children with sickle cell disease. Really, most of this increase in survival happens in infants and in children ages 1 to 9. And this is primarily due, I think, to infection prophylaxis with penicillin and adequate pneumococcal vaccines. So that we can see that mortality decreased 61% in infants when you move from 1999 to 2009 when compared to 78 to 98, and that we've also seen an increase in survival in 67% in children 1 to 4 years of age, and then 22% in children 5 to 19, and this might reflect some of the work that we've been doing with stroke prevention and with hydroxyurea therapy and with early intervention for complications such as acute chest syndrome. Then after 19 years of age, you do start to see still an increase in mortality. Overall, though, from 78 to 2009, there is a tendency towards longer survival as more deaths occurred in the 55 to 74 age group, so we know that that age group is increasing. However, as Dr. Alvarez and her colleagues have demonstrated, there still is this very disturbing uptick in mortality starting at about 20 years of age and then peaking here. And unfortunately, this uptick comes at a time when many young adults are transitioning from pediatric to adult care. So what other components make transition for adolescents and young adults with sickle cell disease difficult and different? Well, we know that there are things that are very challenging with any individual with special needs. We have this 2013 study by McManus published in Pediatrics that demonstrated that there are certain factors associated with successful transition. And this is when I go through these demographics, you'll see that these are not exactly the patient population that I'm taking care of with sickle cell disease. But women tend to transition better than men. And if you start the transition process at a younger age, this is an advantage. Europeans with African Americans and non-Hispanic ethnicity being different risk factors, and also low income. These are really difficult times, and people transitioning in this difficult healthcare environment do better when they have better education and higher incomes in their households. Also, having a medical home gives you an advantage for a successful transition and being privately insured. But we know that in individuals with sickle cell disease, another challenge for transition is the access to adults or experts in adult care management for sickle cell disease, that we see a very challenging, not decrease, but low proportion of providers who have expertise in the care of adults with sickle cell disease, and then trying to find a way to get access to these experts is quite challenging for children and young adults with sickle cell disease. The other challenge is that we really don't have a systematic transition process, the way that we've demonstrated with hemophilia, for example, in the sickle cell community. And this is something that we are trying to get better at and developing programs nationwide and best practices. So unfortunately, as I talk about, Blinder and his colleagues have looked at Medicaid data to see what is really happening across this lifespan in individuals with sickle cell disease and what's particularly challenging about that transition interval. And just at the time when young adults are dealing with the normal life challenges like graduating from high school, going to college, they're seeing an increase in the severity of their disease-related complications. They're experiencing more pain, they're having longer hospitalizations for pain, experiencing more acute chest syndrome, and unfortunately, this is playing out just in this time period as they're beginning to transition into adult care. However, because of primary and secondary stroke prophylaxis, approximately 18% of teenagers and young adults will be on transfusion therapy for primary and secondary stroke prevention. We know that there's an effort to increase the utilization of hydroxyurea therapy to decrease pain and acute chest episodes in young adults and teenagers with sickle cell disease. So we know that there should be greater use of long-term therapies to increase the quality of life of those living with sickle cell disease. So when you look at this in graph form, Blinder has put together this table that demonstrates here on the x-axis, increasing age. And here, the frequency of transfusion therapy. And you can see that the period of greatest use is really under 19 years of age. Here is also the pattern of utilization for hydroxyurea, with peaking just in this young adult age group. And also, this is all complications from sickle cell disease, pulmonary, cardiovascular, infectious. And you can see that just as they're transitioning in this 19 to 22 age range, they're also experiencing this increase in disease-related complications. So imagine what this looks like for the adult provider who's receiving the care of all of these young adults with sickle cell disease, with very, very complex healthcare management issues, with needing to monitor hydroxyurea therapy, which often requires lab values obtained monthly, if not every other month, to monitor for hydroxyurea-related toxicity, transfusion therapy that's occurring every 3 to 4 weeks, chelation therapy that should be going along with chronic transfusion therapy. So we're really taking complex care and delivering it to the adult providers at a time also when the general population with sickle cell disease overall is experiencing more pain, more acute chest syndrome. So we've talked about how we are demonstrating an increased proportion of adolescents and young adults with sickle cell disease, and we've seen an improvement in survival over the last several decades. We've discussed the increased pain, and morbidity, and mortality in the transition age group, and this demonstrates the vulnerability of this chronically ill population. And the increase in the use of long-term therapies will really increase the complexity of care and emphasizes the need for care coordination in this group. So given all of these challenges, you can imagine that when you combine all of this with the life stresses of graduating from high school, going on to college, doing career and planning, peer groups and socialization challenges, how to maintain good physical activity, exercise, and even participation in some competitive sports that most adolescents are struggling with, that this becomes a very difficult time for the teenager and young adult with sickle cell disease. And this is also at a time where we know teenagers are beginning to participate in more high-risk behaviors. We know that this is a time period when they're becoming sexually active. And this really sets the stage to be able to provide good conception, contraceptive counseling, and preconception counseling, emphasizing also genetic counseling. So this gives you the opportunity to talk to teenagers with sickle cell disease about the genetics of sickle cell disease, about contraception, and life planning. So when we're moving to the topic of conception, preconception counseling, and contraceptive counseling, it would be nice to look at some studies that have really talked about the frequency of contraceptive methods used in individuals with sickle cell disease. And this really spans studies from the 1980s to 2010 with many different groups, one U.S. study, one UK study, and one in Jamaica and one in Nigeria, but really demonstrates the wide range of contraceptive use in small populations of individuals living with sickle cell disease. The earlier report in the U.S. reports that only 33 of the group of women with sickle cell disease were using contraception, and that study compared to 66% in the general population. But then in the UK, you can see that there was a higher use of contraception. One of the other interesting things that these studies really reveal is the increase in unwanted or unplanned pregnancies. I will say that in the general population, it's about 50% in the U.S. right now, but still to see 40 to 60% unplanned pregnancies in this patient population is, I still think, very concerning. And we know that pregnancy is not uncomplicated in individuals with sickle cell disease. These are two studies that have really had a deep dive into the complications of women with sickle cell disease during pregnancy. One study out of Atlanta looking at the Grady experience, and another study out of North Carolina looking at their experience at Duke. And you can see that women with sickle cell disease during pregnancy have a very high rate of antepartum hospitalizations. They experience preterm labor at higher frequencies than the general population, preeclampsia. They experience infections, not only sepsis, but pyelonephritis, postpartum infections. And then the births of infants are born premature, low birth weight, IUGR. There's an increase in intrauterine fetal death and perinatal mortality. And these are just the complications that are unrelated to their sickle cell disease. They experience greater frequency of painful episodes during pregnancy, acute chest syndrome, thrombotic complications, including synovenous thrombosis and DVTs. They have frequent use of a need for transfusion therapy for acute anemia and for other sickle cell disease-related complications. And still, these transfusions are associated with alloimmunization. So you can imagine, given the complications of pregnancy for an individual who does not want to become pregnant, it would be very beneficial to provide good contraceptive counseling. So what is a concern about using hormonal contraception in women with sickle cell disease? Well, we know that sickle cell disease is a prothrombotic hypercoagulable state. I think that we have demonstrated in multiple trials that there's increase in thrombin generation, there's increased platelet activation. There's a wonderful review of this topic by Ataga and Oranger, an American Journal of Medicine in 2003. And then there's also clinical evidence of increased clotting. And the Hopkins group, including Dr. Landskron, has published extensively on the thrombotic complications in sickle cell disease. And this includes not only PE and DVT and catheter-related thrombosis, but some of her work has also demonstrated that increase in clotting is associated with pulmonary hypertension and mortality in general. So these are the reasons that people, I think, have been hesitant about the use of hormonal contraception in women with sickle cell disease. So before we talk about what contraception should be used in individuals with sickle cell disease, I want to talk about this phenomenon of pain in sickle cell disease being related to menses. And as early as the early 80s, there were reports that women with sickle cell disease reported increased pain, generalized body pain, painful episodes similar to their pain crises during their periods quite frequently. And this was a follow-up study published in 2002 by Jung and Tuck. It was on a small group of women, but they really went through diaries and demonstrated almost that they could predict when their sickle cell pain was going to come on based on when they were expected to start their menses. And so this association has been demonstrated not only in these studies, but some follow-up studies and the benefits of using progesterone-only compounds, and we'll talk about that in future slides. So are women with sickle cell disease on estrogen-containing oral contraceptives at increased risk for thrombotic complications? I will go through the few studies that there are in the literature. There are not robust randomized controlled trials on this topic. And so these are mainly case-controlled trials and prospective cohort studies. And they're limited by the varying doses of estrogen, either high dose or low dose used in these studies. Some of these studies are on SS only and not including SC and S beta plus. There are varying follow-up periods. It ranges as short a time as 6 months, but some of them are longer in follow-up for about 3 years. And some of them lack really adequate control groups. But for the most part, there is very impressive data on the use of estrogen therapy as contraception in women with sickle cell disease, starting with Lucia et al. In the 80s on 2 trials, one using high dose, both using high dose estrogen, and 31 and then 71 women in a follow-up study. And there were no thrombotic complications reported in these two trials. But what is interesting is that women did report an increase in pain episodes. Then in the UK studies, they followed 67 women with 148 patient years of follow-up. And 2 women experienced DVTs. But I will say, in going back and looking at the study a little bit closer, it is concerning because I'm not really sure what other risk factors existed in these 2 women with sickle cell disease. And it's interesting also that these 2 women went on to become pregnant later and were off therapy and did not demonstrate any recurrent DVTs. But again, this report of increased pain was in the Howard et al. Study as well. And then the only study that really looked at low-dose estrogen, progesterone only, and then female sterilization in 2 and 3 cohort groups side by side demonstrated that there were no thrombotic complications in either group, but that the group that experienced the lowest amount of pain was in the progesterone-only group. So that study questioned whether or not progesterone-only therapy could actually decrease painful events in women with sickle cell disease that were experiencing this increase in pain with onset of menses. So I'm going back to this slide to just again point out that possibly some of this decrease in contraception use could have been underprescribing by the physician because of the concern of thrombotic complications in women with sickle cell disease on estrogen therapy. The other thing that could be a reason for this decreased use is, again, there are myths about pregnancy in women with sickle cell disease. One, some of them believe that they cannot become pregnant because they've been told by either peers or healthcare providers that they should not become pregnant because of the increase in complications, and they've internalized that and taken that to mean that they cannot become pregnant, so they just don't use contraception. So I think that all of these things may be playing into this. So we really have gone through those studies that are in the literature and know that there's really nothing in the literature to support the theory that there's an increased risk for thrombotic complications in women with sickle cell disease receiving low-dose estrogen-containing hormonal contraceptions. And that's really now the recommendation of the WHO, that it is appropriate to use low estrogen-containing hormonal contraception in women with sickle cell disease. So what about progesterone only? What do these other studies from 1972 to 2001 really tell us about the different preparations of progesterone only? And that we don't see any thrombotic complications. I didn't even include it as a column in this table. But again, this phenomenon related to a decrease in pain. And you can see that in most of these cohorts, they reported decrease in painful episodes with the initiation of progesterone-only contraception. But again, there seemed to be, in some of the studies, a suggestion that there may be another reason with possibly an increase in fetal hemoglobin. This was they tried to demonstrate this in vitro and trials as well, and really could not demonstrate this consistently throughout the study. But there is a suggestion that there's an increase in fetal hemoglobin in women who were taking progesterone-only compounds. I can understand the possibility of an increase in hemoglobin because they may have decreased menstrual bleeding, but I really cannot explain this increase in fetal hemoglobin. What are the recommendations regarding hormonal contraception in women with sickle cell trait? As you know, there are reports that individuals with sickle cell trait could have an increased frequency of DVT and PE. Those were studies done by the Veterans Administration, a group in the 1990s that demonstrated that African American men with sickle cell trait had higher rates of DVTs and PEs. And so there was a general concern about the use of these agents in women with sickle cell trait. But as you can see from this table, even though African American women experience an increase in thrombotic complications when they're receiving hormonal contraception, not unlike European Americans, there is an increase in frequency in those with sickle cell trait, but the numbers were too small and there was really no statistical significant difference. But it is concerning to see these these odds ratios in this group. However, again, these are small studies, and I think that the take-home message should be that this is safe to use estrogen-containing hormonal contraception, but that really we need to look further into this phenomenon. So let's go back to question 1. Given inconsistencies and recommendations regarding hormonal contraception use in women with sickle cell disease, may there be decreased prescribing of hormonal contraception, decreased usage of hormonal contraception, increased unwanted pregnancies in this patient population, or all of the above? Well, we have music now. Very good. So the answer is all of the above. And this slide demonstrates our pre and post test that shows that I may have led the audience to all of the above, but I really do believe that it is probably a combination of under-prescribing, under-usage, that really leads to the decreased use in hormonal contraception in women with sickle cell disease. Next slide. So when you go through the CDC recommendations, and these are the ones that were originally published in 2010, and as you know, there was an update in 2013. We can go through and see what the appropriate contraceptive method should be when talking to young women with sickle cell disease. And really, I think the combined hormonal contraception should be considered when counseling these young women, because sickle cell disease is a condition in which the advantages of using combined hormonal contraceptive agents generally outweigh the theoretical or proven risk. Combined hormonal contraceptives, however, are not recommended for women with a history of stroke or DVT. As you know, that's not recommended in the general population as well. So I think that if a young woman who had a prior history of a catheter-related clot was coming in for advice regarding contraception, then I would avoid estrogen-containing compounds. However, I would offer progesterone-only contraceptive to those women. I think the other group that is going to be very difficult to figure out what we're going to do with is those individuals who were on chronic transfusion therapy for primary stroke prevention. I know that the philosophy behind the vaso-occlusion that really leads to some of the issues around stroke in individuals with sickle cell disease usually have a different underlying pathophysiology. However, with that cerebral vasculopathy, thrombosis is sometimes associated, particularly in the setting of acute chest. So I think it's going to be difficult to figure out what we're going to recommend to those young women. And right now, I think I would probably take the conservative approach and offer progesterone only. I think the other challenge is as more individuals with sickle cell disease are treated with chronic transfusions, we really see more permanent catheters being used as they age. And I think I would be very hesitant to put a patient with sickle cell disease who had a Broviac or a Portacath in on an estrogen-containing compound. I think I would use progesterone only in that situation as well. Sickle cell disease is considered a condition where you can use copper IUDs. However, there have been associations of increased menstrual bleeding in individuals with copper IUDs in the general population as well. Many young women are selecting levonorgestrel IUDs for use for contraception. There's no restriction for the use of this method. A history of either stroke or venous thromboembolism is considered a condition in which the advantages of using this method generally outweigh the risk. Of course, there's no restriction for barrier methods, female sterilization, particularly in older women with sickle cell disease that want that option, possibly, and male sterilization. So let's go back to question 2. The recommendations for contraception in young women with sickle cell disease and no neurologic or thrombotic complications include A, progesterone-only containing hormonal contraception medications, low-dose estrogen-containing, barrier methods, all of the above, and then the last option was A and C. Very good. So let's see what we said for the pre and post test. The answer is all of the above. And we can see the selection there. And that was the green bar and then for the initial and then the red bar for the second. So excellent. So in summary, I think that we've seen the proportion of individuals with sickle cell disease in the adolescent and young adult age group increase. I think that this is probably due to an early diagnosis with newborn screening and infection prophylaxis, but also the improved care with hydroxyurea and chronic transfusions in this patient population, and as well as comprehensive care. I think that we're going to see the increased utilization of chronic transfusion methods, particularly around primary and secondary stroke prevention in this patient population, and also in the use of hydroxyurea. And I will say that I want to give a plug for the NHLBI care guidelines that I think will soon be published and address not only the issues of chronic transfusions and hydroxyurea use, but also hormonal contraception use in this patient population. Adolescent girls and young women with sickle cell disease need safe and effective contraceptive methods to prevent unintended pregnancies. And I think the open conversation needs to be started in the pediatric practice and really can be used by the pediatrician to address the concept of transition of care. And this might be just the ideal time to involve the care of family practitioners, internists, GYNs to participate in the care of these teenagers with sickle cell disease. They could even have a trial transition from their primary care providers while still being cared for maybe by the same hematologist before that hematology transition occurs. So this might be a pre-transition event that it's really, I think, the ideal situation around the use of contraception and preconception counseling. The increased risk of thrombotic complications in girls and women with sickle cell disease necessitates careful attention when selecting hormonal contraception. And we can see that combined hormonal contraception, even those with low-dose estrogen, can be safe in adolescents and young adults with sickle cell disease who have not had a stroke or a thrombotic event. Progesterone only is an option for those in the latter category, and also in those that are having increased pain around menses. Progesterone only compounds may be useful, as well as hydroxyurea in that group. And hormonal contraception appears to be safe in women with sickle cell trait without other risk factors, but we know that further research really is needed in this area. Thank you.